Let me just mention one thing with the spines. People were asking,
What time's our test?
6 spines. Okay, just one quick one.
I'm sorry. I'm
Sorry.
So spines, you're looking at, just stand right here. So the first thing we're doing is we're looking at the spine for normal curvature, cervical, thoracic, and lumbar. And we're also now going to inspect for scoliosis. People are asking me about bending or not bending. So can everybody see? Yeah. So we're looking at the height of the shoulders. We're looking at the height of the iliac crest to make sure they're symmetric. You don't have to do this bending because if my hands are on Jason's iliac crest, please bend forward. Do they move at all? No. Okay, so shoulders and iliac crest, you just look at standing. You look at the spine when the person is standing, and then you look at the spine, please bend over like you're going to touch your toes, and you look at the spine again, and you may see some curvature that you don't see when he's standing. Thank you.
Do you have to name the curvature? Like concave, concave, no, or?
No. You could just say the spine appears normal. Quick, to the point. Okay. Palpate spinous processes. Which is the most prominent? And what if there are two that are prominent? Yes, C7, T1. So palpate the spinous processes and paravertebral muscles and the sacroiliac joints where the dimples are. Okay, and you're palpating for tendons. Range of motion of the neck. Please demonstrate the range of motion of the neck. What is, no, slowly. Do the first one. What is this? Rotation. Good. Yes. What is this?
Bending.
Lateral flexion, good.
Extension.
Do we have to say that?
Do we have to say that? Teacher might not know what that means, so we just say we're touching their range of motion.
No, you want to instruct the patient what to
Can we
do.
just say like, touch your chin here?
Yeah, absolutely.
You don't have to say like, touch it.
Absolutely. You don't have to say what it is you're doing. You just have to instruct the patient to do all of those.
Oh, okay. That was gonna be my question.
You should just know which one.
No, don't say I'm looking for. Just instruct your patient what to do. Yes. Range of motion of the spine. What is that?
Rotation.
Good. Good.
Extension. Flexion.
Good. Lateral bending. Good. Demonstrate the Sperling maneuver. Are you having numbness, tingling in your left arm?
Yes.
Okay. So the patient should turn his head which way?
To the left.
And
Slightly up. Look up.
slightly up.
Slightly up.
And then you apply.
Downward pressure.
It reproduces the thing. Good. Thank you. Okay, I think that was it for the spine. Okay? You want to observe the patient's gait and you want to inspect the lower extremities for any muscle atrophy. Palpate the hips, the hip landmarks. We went over this earlier. Iliac crest, ASIS, PASIS, SI joint. Greater trochanter. It's fine. Range of motion of the hips. Would you demonstrate standing? Jason's going to demonstrate. Please say what he's doing.
Internal rotation. Extension.
Two more. Okay. Palpate the knees. Name the landmarks. What landmarks do we need on the knees?
The meniscus. The condyle. Tibial tuberosity. Patella tendon. MCL, LCL.
Okay, femoral condyles you don't have to point out. But put your fingers in the joint. The joint is between what and what? Tibia and femur. Good. Make sure your fingers are in the joint. Okay, they should be. You should feel the tibial plateau. Where do the menisci sit? On the tibial plateau. You're not going to be able to palpate them, but you could just verbalize. The medial meniscus is on the tibial plateau medially, the lateral is there. What sits where my hand is along the medial aspect of the knee joint?
Medial collateral.
Yes. MCL. What sits along
LCL.
Okay, great. Again, you're not going to be able to palpate those. What sits across here? And what sits across the back? Great, great. Relax. What do we palpate first here? Good. And then below the patella is, and then further down we feel on the tibia. Tibial tuberosity. Excellent. Did I miss any landmarks? Okay, you're not going to be able to palpate the bursa unless there's a problem, but let's talk about the bulge sign. You can list them, you can say it just sits there. Yeah, you're not going to be able to palpate them. So just so. Okay, for the bulge sign, we're putting our hand over the
Patella tendon.
suprapatellar area, and we're milking down. With the person supine, the leg has to be extended, and you milk down from above with one hand. Milk down, and then any fluid that's there is potentially down low. Then you're applying pressure medially, so you're pushing whatever fluid is there to the lateral aspect here. And then you're going to see if you're palpating here to see if you feel something volatile, if you feel fluid, if you feel soft. Okay, bulge sign.
Anterior drawer.
Okay, now we'll go over the different maneuvers. Anterior, yes.
Do you need to also show the posterior and dorsal?
No. Roughly. Yeah, but you don't have to do that. Okay, anterior drawer checks for integrity of what? Right.
What?
The ACL, the anterior cruciate ligament. If that's torn, then what will happen is when you pull, the tibia will be driven forward. So with the patient supine, leg flexed to roughly 90 degrees, stabilize the foot. If you don't stabilize the foot and you pull, the leg is just going to straighten. So you must sit on the foot. Do something to stabilize it. Grasp the tibia with both hands. Your thumbs should be in the joint space, and then you're pulling to see if you feel the tibia come forward. Okay, anterior drawer. Posterior drawer, you're still placed over the foot, and you're pushing backwards. You're feeling in the joint space to see if the bone, the tibia, is moving backwards relative to the femur. Posterior drawer checks the integrity of what? Excellent.
Yeah.
What do you mean?
Their foot will be on the table.
Yeah, it will be on the table, but you have to stabilize it, because if it's not stabilized, if you don't anchor it here when you pull, the leg is just going to straighten. Right. So you must stabilize it there. Are you okay?
Like Murray.
Yeah, let's first do Lockman. So Lockman tests for what?
ACL.
ACL also. With Lockman, there's only about anywhere, depending on what you read, 15 to 30 degrees, a little bend in the knee. And then you're going to apply a downward pressure on the femur and an upward pressure on the tibia. So basically the same thing as the anterior drawer, but you're doing a down and an up. And you're,
Wait, you're not just.
no, you're pushing down with the femur and up with the tibia. So it's doing the same thing. You're seeing if the tibia goes forward or goes up. No, there's a table. He's laying down. He's laying down. And we're right around the knee, so you don't have to stabilize something. You see, because the foot, because I'm pushing down and I'm pulling. Pushing down on the distal femur and up.
On the dorsal side.
Yes. Yes.
But you're just pushing on the dorsal side. You're going like this.
Let's just do the valgus and the varus. Valgus, You have to also stabilize the lower leg, and you apply a valgus pressure, pushing the knees together. This is testing for what? Yes. If the MCL is torn, then these bones, ligaments hold the bones together. The tibia and the femur will separate. So as you're applying the pressure, you want to feel if that joint space widens. No, I'm just stabilizing here. I'm not doing McMurray. All I'm doing is a valgus stress. Valgus stress for MCL. What kind of stress do we apply to test the integrity of the LC?
Varus.
Varus stress. So same thing, knee slightly bent. Press outward, feel the joint space on the lateral aspect, varus for the LCL. McMurray, we're checking the menisci, so we want to put stress where the meniscus is. So if we're checking the medial meniscus, I want to apply exactly, and I want to rotate. You know, we were talking about rotation of the knee, external, the opposite way. So we're putting maximal stress in the area where that medial meniscus is. Okay, so with the knee and the hip flexed to about 90 degrees, the patient would be supine. So let's imagine he's supine. Just don't fall over. Okay, wrap your hand around the knee. The palpating hand should be on the tibial plateau, and you're applying valgus pressure. The other hand is on the heel. So I'm pushing in, but I'm feeling here. I'm feeling medially where the medial meniscus is. I'm turning the heel outward, so it's rotating the tibia outward a bit, and then I stretch the leg down. And I'm feeling with this hand for what? Click, pop. There may be an audible sound.
Really have to do it once?
That's it. Yep. You could repeat it a second, just bring it back a second time if you're not sure. For the lateral meniscus, you're doing everything opposite. Right. So with the lateral meniscus, we're going to apply pressure. What kind of pressure? Varus. Varus. So I'm pushing outward. Let me do it this way. I'm pushing outward, and I'm feeling on the lateral aspect. And which way am I turning the heel?
Internal.
Internally, right. Start with the leg at 90 degrees and then stretch it down.
Why the heel not just
This is, yeah. Okay, and then landmarks in the ankle and foot. What do we have here? Other side? Here? Good. You don't have to say posterior inferior, just say calcaneus. What bones are in the joints here? You don't have to, you don't have, this is the ankle joint. Make sure you palpate the ankle joint. And then, what do we have in metatarsals and these? And what is this joint called? MCP is where? In the hand. By the way, where is the MCP joint? We didn't go over this. Okay. Nobody is pointing to the right spot. Okay, it is not the knuckle. The knuckle is the end of the metacarpal bone. The joint is distal to the knuckle. Distal to the knuckle. This doesn't bend. The joint is right here. Distal. So when you're palpating for MCP tenderness, who gets tenderness and inflammation in the MCPs? People with what disease?
Typewriters.
Rheumatoid arthritis typically affects the MCPs. This is where you're palpating the joints, not on the bone. This is bone, this is not joint. Joint is an articulation between two bones. The knuckles are actually the distal aspect of our MCP, of our metacarpal bones. And the joint is just distal to that. Okay, same thing on the feet. Okay, so you're palpating where the toes bend. Okay, you can also do a squeeze test. Why would we squeeze the metatarsals together? What condition on the bottom of the foot, say between the second and third metatarsals? Morton's neuroma, excellent, yeah.
Yes, Sam.
Between the second and third metatarsals, when you do the squeeze test, it would elicit the pain. So we did the malleoli, the calcaneus. Plantar fascia. Plantar fascia is all along the bottom of the foot. If somebody has plantar fasciitis, when you press, specifically near the heel, it's going to be tender. If you had plantar fasciitis, it wouldn't feel good. We didn't go over the wrist. We didn't do the upper extremity. Yeah. I'm sorry. And then anterior drawer of the ankle, same thing as the anterior drawer for the knee. You're going to stabilize the tibia, and you're going to grasp the ankle, grasp the foot by the calcaneus, and see if it draws forward. Pull it forward. Anterior drawer. Okay? And that's to check for torn ligaments. And straight leg raise, you all know, right? Yes. And cross straight leg raise.
When you move your knee in, that's external rotation of the hip, and when you move your knee out, that's I'm getting
Okay, so there was a question about which is external versus internal rotation of the hip. Hips in a neutral position. Take your foot and turn it out.
so I can just ask my patient to do
That's
this.
external rotation.
And that's it.
This is internal rotation.
Okay, so I can just
They
ask them
use-
to do that.
But, so we move the knee to make it easy. You can see a full range of motion.
Okay,
The
so
truth is,
video-
when your foot is planted on the ground, you're not doing full external rotation.
Because the video was like really confusing. Like I watched like
What? Yeah, why?
I don't know. I was trying to figure it out.
No, Sam, there's a part where they reverse it. And they like,
Yeah.
they say like that's the internal. I know what you're talking about. Oh, it's
You just lift it. Cross
I know what
straight
you're
leg
saying.
raise. So it's a straight leg raise, but it's crossed, meaning it's the side opposite where the person is.
So you do raising the leg.
You what?
You're just raising one leg, and if it's the straight leg, it's just
Straight leg raise, it's the leg that's affected that you're raising. Cross leg raise, you're raising the leg that feels fine and it's eliciting pain in the leg.
So how are we demonstrating both those steps during the
Oh, you say if the person had sciatic symptoms here, this is a straight leg raise, this is a cross leg raise.
it's active, right? Wait,
Huh? It's active. It's passive. It's passive. You're active. You're lifting the leg. Yes.
At 73?
At least 60 degrees. You may raise it to 90. You could dorsiflex the foot to add a little more flow. Other questions about spine and lower extremity?
Yeah, where you going?
No, you should do straight leg raise and cross leg raise. There's only Now it's really neuro, but I put it on here because there were too few things on here and too many on the neuro. So you would do that to check for sciatic. For the ankle, yes. Yes.
Fucking 12-course meal over here. French courses over here.
Yeah, that's why I didn't get the one I got it.
I can't do that. I can't do it.
Okay, so the question was about the range of motion of the ankle. You don't have to have the patient walk on their toes and heels and walk on the lateral aspect of the foot and the medial aspect.
So how should we test for it?
Just range of motion. Just flexion, extension, internal rotation. Yeah, thank you. You don't have to people walk with that. The walking you'll do with the toes and the heels and hands. I'm gonna put all the things that I'm asking you to do on the rubric for the proctors. So they will not be looking at this long sheet. They're just gonna know, but yeah. Any other questions on lower extremity? Okay, should we do upper extremity or yes? So for upper extremity you have the spine, and then we did the curling. extremities, you're looking for symmetry of the muscles, you're looking for fasciculation. Palpate the shoulder, shoulder lamina. Did you get a t-shirt on?
Okay, Jason.
You don't get.
Jason, get naked.
Andrew, can you send that video after?
Yeah, it's Lexi's. I'll ask
Oh,
her.
okay.
Lexi, she asked if you could send that video to me.
No.
No, she's joking. She's joking. She's a comedic.
I just
You said you're a comedic.
Proud. Like I could go to the sauna and shit.
wanted to video Jason.
I just hear.
I was joking.
No, I don't.
Pick that up.
Okay, I would recommend.
It's Lexi's, but yeah.
Start
She's
at
that's
the,
good.
what angle is this?
Yeah, you got Julia. Julia, get out of my view.
Walk your fingers along the clavicle as far as you could feel, and then stop. Then take the other hand, walk along the, and walk along that until the end. What is that thing called?
AC joint.
No, what is the end of the,
Oh,
the
acromion.
acromion? And the space between my fingers right now is the, which stands for acromioclavicular joint. So here's the acromioclavicular joint. What happens this, oh, you know what, let me not give you stuff that's not on the test, but, okay, from the AC joint, if I feel slightly inferior and medial to it, and deep, I feel the, what bone is the coracoid coming off of? Okay, why are these two spots important? Yes, rotator cuff. All of those tendons from the rotator, the supraspinatus tendon is in there, and all the maneuvers that we're going to do, we're going to crunch up this space. We're going to affect this space and see if it elicits symptoms. So that's why we want to know where this is. The most prominent part of the shoulder here is called the. Okay, and then we can palpate along. Now I like to do this to find, what am I looking for?
Biceps tendon in the intertendon.
Yes, biceps tendon in the intertubercular groove. Right, so you can follow the biceps muscle up, and then just relax your legs. And then you should feel the bicipital groove. You okay? Okay.
That's kind of good on it.
Okay. So right in there, and if somebody has tenderness here? Excellent. Okay, I think that's it with the landmark. The what? Oh, okay. So the bursa are very hard to palpate. They're underneath the acromion. If they're inflamed, you would feel them. You don't have to demonstrate them. But just know sub. Sub is what? Acromion? Yeah. So again, I've never felt them. If somebody has subacromial bursitis, you will feel it in that subacromial area.
Do we need to say that for the practical?
No. Okay.
Great at choking.
Oh, yes, right. And then where is the supraspinatus muscle? Above the spine. Where is the infraspinatus? Good, that's fine.
You don't see Terry's or whatever.
Teres minor, are you able to distinguish where it is? On exam, on external exam? You can?
You can kind of
Where is it?
off the bottom.
One at the top third of the line of one of the stop.
Do you feel it?
This is the origin instructions, bro.
If you just say supraspinatus, infraspinatus, that's fine. Supraspinatus above the scapula spine, infraspinatus below.
And
Okay. Oh, range of motion of the shoulder. Please stand up and demonstrate. Everybody say what Jason is doing.
Abduction.
80 to.
Extension.
What the? I always tell him when he does that it's not normal. I try to tell him it's not normal. He tries to tell me that's external rotation.
Okay, no, do it that way. What one person said, do you guys know what that movement was?
Yo, you can be like a slapping champion.
Okay, halfway scratch this.
Yo, tag in, Lexi. I'm tired.
Good, good. Make sure you do it bilaterally. If you want to do both hands at the same time, you can also just demonstrate what you want the patient to do. Okay, near impingement. Active or passive maneuver? Passive. Good. And what do we do?
Hand on the scapula, raise the arm.
Correct. Okay. Yes, Hawkins impingement.
90.
Yes. And then you do internal rotation effectively. Okay, I'm exaggerating. Turn this way. Yep. Empty can. Yes, empty can. You can do both hands at the same time. Do both hands at the same time. Apply pressure. Don't let me push your hands down. Good. External rotation leg. So I put these in instead of all the other things that we were doing. With the patient sitting, have the hands, this is external rotation, resting on the lap. You can demonstrate to the patient. I want you to move your arms out and fully supinate. Keep your palms up and push out against my hands. You can apply a little bit of pressure. In somebody who has a rotator cuff problem, they're not going to be able to even maintain their arms out to the side like this.
No way. No.
Yeah, you don't have to look at it.
Okay, so external rotation leg. Internal rotation leg is basically the Gerber lift off. Put your hand behind you, palm facing up. And you could either lift the hands out and tell the patient to maintain it if they're weak. If they're strong, you could say resist my pressure. No, just demonstrate. Demonstrate external rotation leg, internal rotation leg. You're rotating the shoulder externally. Yes.
Is there any way you could like cross out the stuff we don't need to do and re-upload? Like there's so much I feel like that we like crossed out or added, like changed.
I will write in it, yes.
Okay, thank you. Just like the ones you either stronger.
Drop arm test. So drop arm test. Put your arms out. How many degrees? 90. Good. And slowly lower your arms. Okay. Good. Elbow landmarks. Medial what?
Fuck my legs. Not good.
Good. That's fine. So don't. But if it's not, Guyon's canal is there. Correct. But what's here in the elbow?
Cubital fossa.
Yeah, the condylar groove, that's where the ulnar nerve is. So the ulnar nerve runs between the olecranon and medial pronotum. Range of motion of elbows, please demonstrate. Close-in test. Make a fist, lift it up, and resist my pushing down. Don't push this way. Resist my pushing down. You can have your hand, relax your arm. You can have your hand on the lateral, near the lateral epicondyle. Make a fist, and you can say, let me know if you feel pain where my finger is.
Yeah,
Don't let
I
me
think
know.
in general, and it offers that little bit.
Yeah. Yeah. Golfer's elbow is. Yeah. You don't have to do reverse. Wrist and hands landmarks. What's this? Which thyroid?
Ulnar.
Look at it.
Oh no.
Okay. Palpate the wrist joint. And what bones are over here? What bones are these? And where is the MCP joint?
Distal to the knuckle.
Yes. Everybody should palpate their MCP joints. Distal to the knuckle. And what are these?
PIP.
Well, what are these called?
PIP.
Good. And what's this joint called?
PIP.
And what's this called?
DIP.
And what's the one on the thumb called?
DIP. Oh, IP.
I do.
And then
Good. Okay. Range of motion. Range of motion of the fingers without the thumb. Range of motion of the fingers. What is he doing?
abduction, flexion, extension, adduction.
Opposition.
Okay, now thumb. Range of motion of the thumb.
Abduction, opposition, flexion, extension.
Oh, and one more. Yeah, opposition.
He did it.
Okay. Okay, good.
Do the radial and ulnar deviation.
Oh, we didn't do wrist. Yeah, we didn't do wrist range of motion.
Radial, ulnar.
Good. Good. Yeah. Thank you. Yeah, but also ulnar deviation. Where's the ulnar?
Well, for flexion and extension.
Oh, yeah. Okay. Oh, yes, thank you. Okay, Tennelle sign.
Where are you tapping?
It's a tap. It's a tap, not a touch. So here I'm touching.
I thought it was a rub, not a touch, but it's a tap.
It's a tap.
Okay, shit.
Phelan sign. Please demonstrate Phelan. No. Back in.
Hold for 60 seconds.
Yes.
They don't actually have to hold it, right?
Yeah, no, verbalize that they should hold it for 60 seconds. And Finkelstein test is for,
T. corvinus, tensinovitis.
right, so the thumb goes inside the fist and you extend to stretch it. Good? Any questions?